Hi, my name is Jordan Karlitz. I'm one of the senior medical directors of medical affairs at GRAIL, and I'm going to be talking today about the promise of multi-cancer early detection, or MCED. And just by way of disclosure, I am an employee of GRAIL. So just to give you a little bit of background information on myself, I am a GI doctor. I've been in practice for many years. I was at Tulane for quite a while, where I started a hereditary colorectal cancer program to screen patients for Lynch syndrome and polyposis syndromes. And most recently, I was at the Denver Health Medical Center, which is a large safety net hospital in Denver that's part of the University of Colorado system, where I was chief of the GI division, and a lot of what I did was focusing on colorectal cancer screening, overcoming barriers to screening, and just kind of focusing on GI oncology in general from a GI luminal perspective. I wanted to welcome everyone here today, and we're going to get started. So the scope of the problem is that 70% of cancer deaths are actually due to cancers with no USPSTF screening recommendations. So we need a test that's able to target this 70% and also supplement the 30% of cancers that do actually have screening recommendations. So this 30% here represents the patients that are able to undergo USPSTF screening. So that would include screening for colorectal cancer, cervical cancer, lung cancer, and breast cancer. So I do want to give an overview slide of the multi-cancer early detection test that was developed at GRAIL. So it's based on a single blood draw, and the test is able to detect a cancer signal by looking at methylation sequencing and machine learning classifiers. So once you draw the patient's blood, if there is methylated DNA present, through machine learning, we're actually able to look at that methylation pattern and predict with about 90% accuracy of what organ that signal is originating from. And a really important point here, and I already alluded to this on the previous slide, is that this test is not meant to replace USPSTF guidelines. Rather, it's necessary to target cancers that are not covered by USPSTF guidelines, and also supplement cancers that may be covered by USPSTF guidelines, but due to compliance issues, maybe patients are not undergoing these screening tests. The test is designed to detect a cancer signal common to more than 50 different kinds of cancers. And another key point is that the test is very specific. So the specificity is actually over 99%, which means that there are very, very few false positives. So in terms of the biology regarding cell-free DNA, so on the top here, we could see blue cells, which are normal tissue, and on the bottom we could see tan and brown cells, which represent cancer. So in both of these cases, both in the normal circumstance and in tumors, cell-free DNA is going to be secreted in the blood, but the methylation patterns between these two are going to be different. And that's what we're able to detect. We're able to look at the differences in cell-free DNA patterns between these two circumstances, and then give an indication of whether cancer is present, and then through machine learning, look at the methylation pattern and subsequently predict with 90% accuracy what organ it's coming from. I do want to make a clear point here that this is not a test. This is not germline testing. So we're not looking for predisposition to hereditary cancer syndromes such as Lynch, FAP, hereditary breast ovarian cancer, et cetera. What we're looking for is DNA that is secreted by tumors in real time. So again, not a hereditary risk assessment tool. So this slide just shows the methylation patterns between a patient with breast cancer and a matched non-cancer participant. And the take-home point here is that methylated DNA is in red and non-methylated DNA is in blue. And you can obviously see a clear pattern here where there's a lot of methylated DNA in this cancer patient compared to this matched non-cancer participant. And by applying machine learning, we could actually look at this methylated pattern and predict, again, what organ this may be originating from. So in this slide, this really summarizes the process of testing. So in this case, a patient has what looks like a stomach cancer. The tumor is actively shedding cell-free DNA fragments into the bloodstream. Blood is drawn, and then through targeted methylation analysis of the cell-free DNA, we are able to subsequently use a machine learning classifier and not only detect a cancer signal, but also predict the organ of involvement. Then obviously the other result would be that there's no cancer signal detected. So before we delve into details on the PATHFINDER study, which is one of the main points of the talk today, I do want to talk about some of the studies that have already taken place or are also in progress. So one of the big studies was the Circulating Cell-Free Genome Atlas, or the CCGA study, which was already published. So there was a validation study that was published last year in Annals of Oncology. And the CCGA study is a case control study, meaning that we had a certain number of patients with cancer and a certain number of patients without cancer, and we were able to do MCED testing on all these patients with cancer and without. And that allowed us to calculate certain metrics like specificity, sensitivity, PPV, and negative predictive value. The PATHFINDER study, which I'm going to present soon, is not a case control study. It's a prospective study where participants were enrolled at day 0 and then followed over time. They had testing and then Gallery testing or MCED testing, and they were followed over time at that point. So we'll get into the details of that shortly. I do want to state that the clinical development program at GRAIL is very robust. We have a number of studies that are ongoing or have completed that involve 335,000 participants. So I already mentioned the CCGA, which is a case control study that allowed us, again, to calculate important metrics, including specificity, sensitivity, and PPV. This study had 15,000 participants. The PATHFINDER study, which again, I'm going to present soon, had about 6,600 patients. There's something called the NHS Gallery study, which is a prospective study in the UK, which just completed enrollment and has 140,000 patients. So we don't have information from that study yet because the enrollment completion just occurred. But this is an ongoing study, which is going to, we're going to be able to obtain a lot of important information from that study population. And then 2 other studies that I want to mention are the Reflection study, which is a real world study where we're looking how Gallery is being interpreted and implemented in the community. And then finally, there's PATHFINDER 2, which in distinction to PATHFINDER, which I'm going to present today, PATHFINDER 2 really expands our patient population to more of an underserved population. So I think that's going to be, the results of that will be very important. So based on the CCGA study, again, the case control study, I do want to go over some key metrics of the test. I've already gone over a few of those. As I mentioned, the MCED test could detect a cancer signal from more than 50 different types of cancer. The PPV is very high based on CCGA of 44%. Specificity is very high with a false positive rate of only 0.5%. The sensitivity for stages 1 through 3 cancers is 41%. But if you actually look at a subgroup of cancers that are more aggressive, for 12 cancer types that are more aggressive, the sensitivity for stages 1 through 3 is actually 68%. And that's because these more aggressive cancers, for example, esophageal cancer, pancreatic cancer, ovarian cancer, have more of a tendency to secrete cell-free DNA into the blood. So we're able to detect that more easily than some more indolent cancers, for example, prostate, thyroid, and some other cancers. And then in terms of the accuracy of the methylation pattern where we could predict the organ involvement, the accuracy from CCGA was about 89%. And again, we'll go through PATHFINDER and compare it to the CCGA study. So again, this is from CCGA. These are the sensitivities for different cancers. So you could see that there's a wide range of sensitivities, but a lot of the aggressive cancers here are grouped on the right, where the sensitivity is fairly high. This is for all stages combined. I do have a slide that shows a stage breakdown. But for example, for liver bile duct cancer, the sensitivity was about 93.5%. For head and neck cancer, sensitivity was about 86%. Pancreatic cancer, which I know is something as a gastroenterologist I was often dealing with and wanting to rule out in my clinic, the sensitivity was 84%. Ovarian cancer, 83%. And then you start going down, when you start reaching more indolent type cancers, the sensitivity could drop off considerably, but a lot of these aggressive cancers were able to pick up these cancers in fairly large numbers. This is a stage stratified slide, which shows 12 more aggressive cancers and stratified by stage 1, 2, 3, and 4. So anal cancer, bladder, colorectal, etc. Again, stages 1 through 4. I'll bring your attention to ovarian cancer, for example. So stage 4, we're picking up 95% of those, 87% of stage 3, 80% of stage 2, and 50% of stage 1. So some people may say, oh, well, you're only picking up 50% of stage 1 cancers. But we have to remember that ovarian cancer is not something that we could typically screen for. So really, effectively, the sensitivity in real world setting is 0. So even if we're detecting 50% of stage 1 and 80% of stage 2, that is a win for many patients. For pancreatic cancer, we are detecting about 62% of stage 1 and about 60% of stage 2 cancers. Liver cancer, which is something that I deal a lot with, again, as a GI doctor, especially with rising rates of fatty liver and hepatitis C, hepatitis B, we're picking up very high numbers of stage 1 and 2 cancers. So the sensitivity for stage 1 cancer was actually 100%, 70% for stage 2, and 100% for stage 3 and 4. So these definitely vary based on the cancer and the stage, but we are detecting a very good amount of early stage cancers. So this slide, I guess the best way to frame this slide is that the aforementioned metrics demonstrate the power of Gallery to allow us to change the paradigm of screening and really screen for the 71% of cancers that have no USPSTF guidelines. And it also allows us to supplement the 29% of cancers that do have single cancer screening guidelines, but are associated sometimes with low screening rates. So for example, in breast cancer, colorectal cancer, and lung cancer, you could see the adherence rates to single cancer screening, and these are obviously not optimal. So for lung cancer, for example, adherence to screening could be under 5%. For colorectal cancer, it depends on what modality you're using, but it could be as low as 29.5%. For breast cancer, it could be in the 60 to 70% range, and similarly, in a similar fashion for cervical cancer. And also, a lot of times, providers may not actually order single cancer screening tests. They may, be pushing it off to the next visit. So it may not even be an adherence issue. It may actually be an ordering issue. So again, the MCED test or Gallery is not meant to replace USPSTF guidelines, but if there are issues with people getting their testing done, the Gallery test could provide a safety net for those patients by offering an additional modality on top of what they should be doing already. So this slide really allows us to see the number of cancers involved. So Gallery is modeled to find 420,000 cases of cancer per year. And of these 422,000, 327,000 cancers have no recommended screening. So this is really the main point here, is that we're going to, through Gallery testing in large populations, we're really going to be able to pick up a lot of cancers that we'd really have no chance to pick up otherwise, unless the patient presented with symptoms and had a diagnostic workup or had something found incidentally on imaging for another reason. Based on modeling data, by adding Gallery to usual care in 50 to 79-year-olds, we could actually detect 68% of the most aggressive cancers that are expected to cause death in the next 5 years. And of these 68%, we could actually prevent death in 39%. So I think this is a very powerful slide. And on the right here, we could see the number of deaths potentially averted annually in two situations. The first is what we're doing currently with screening, so with USPSTF guidelines. So we're able to avert just over 100,000 cases of cancer deaths per year. But if we were to add Gallery or GRAIL MCED testing to this paradigm, we'd be able to avert probably about 110,000 deaths per year. So that's pretty much equal here. So we're pretty much able to double what we're doing already, which is a testament to what the test can do. So I do want to go over this slide because it talks about the challenges that are associated with single cancer screening. So I already mentioned that there are adherence issues and ordering issues with single cancer screening, but I want to draw your attention on this slide to the metrics for single cancer screening. So specificity and PPV specifically. So as I mentioned before, the Gallery test has a specificity of about 0.5% and a PPV of about 44% based on CCGA data. We could see here that for breast cancer screening, cervical, colorectal, and lung, the specificity is considerably lower than Galleri testing, which means that the false positive rate is higher, which means that you're doing unnecessary diagnostic workups in a lot of patients. And I also want to draw your attention to the PPV for a single cancer screening test, which in all cases is under 10%. So the Galleri test has a PPV of 44%, which is actually quite high. So again, just to remind people about the PPV, that means if you have somebody sitting in your office that came in with a positive Galleri result, their individual chance of having cancer on diagnostic testing is 44%. If you had mammography results that was abnormal and you did diagnostic testing, the PPV is about 4.4%, so that's considerably lower. So that patient would have about a 4 to 5% chance of having cancer on that subsequent diagnostic workup. So now I want to delve into the PATHFINDER study. So this, in contrast to the CCGA study, which again was a case control study, the PATHFINDER is a prospective, multi-center, interventional return of results study. So adults 50 years and older were enrolled from 7 US sites, and they were divided into 2 different cohorts, those with and without additional risk factors. I do have a slide coming up that will go over those additional risk factors. So all these patients were enrolled, the MCED test was ordered, a questionnaire was given to participants, blood was drawn and shipped, and at around day 15, a test report was generated, and there were one of 2 results. There was either a signal detected or no signal detected. If the signal was detected, we assessed how long it took for diagnostic resolution, meaning whether cancer was present or not. And I should mention that in both circumstances, whether there was a signal detected or no signal detected, we did follow patients out for 12 months. So I think that's a key point of the PATHFINDER study. We didn't just do the test and do diagnostic testing and just kind of let them go. We did follow all patients for 1 year. So this is a slide that I was talking about that delineates patients with the 2 cohorts, cohort A with additional risk factors and cohort B without additional risk factors. And again, all these patients were 50 years of age or older. So those with additional risk factors included smokers, those with a hereditary or genetic cancer predisposition, and some patients had prior cancer with treatment, but it had to be completed more than 3 years prior. And then those without additional risk factors were healthy people 50 years of age and older without major cancer risk factors. Key exclusion criteria included undergoing or being referred for diagnostic evaluation due to clinical suspicion of cancer. So that means, for example, if you had a patient with abdominal pain, vomiting, and a 30-pound weight loss, which is something, unfortunately, I'll see in GI clinic fairly frequently, that type of patient was excluded from the study because there was obviously a concern that that patient had cancer. I should mention, though, that patients were allowed to have symptoms in PATHFINDER, but they just couldn't have symptoms that were highly suggestive of cancer. So again, a patient like that with abdominal pain, vomiting, and weight loss, that patient would be excluded from the study. Another exclusion criteria was a history of or treatment for invasive hematologic malignancy within 3 years prior to enrollment date, or diagnosed more than 3 years prior but never treated. So the study objectives could be divided into the primary objectives and the secondary objectives. The real focus of the primary objectives was to assess the extent of diagnostic testing required to achieve the diagnostic resolution after the patient had a positive blood test. So some of the things that we looked at are number of imaging tests and invasive tests and procedures, labs that were ordered and resulted, number of clinic visits, and then just overall time required to achieve diagnostic resolution, which was defined specifically as the number of days from when the test result is returned into the reporting portal to the date of diagnostic resolution. And then secondary objectives of the study were really to evaluate test performance. So some people would get confused about PATHFINDER thinking that test performance was actually the primary objective, but it was really the secondary objective. So we were able to calculate PPV, NPV, and specificity. We were not able to calculate sensitivity in contrast to the CCGA study, because if you remember, PATHFINDER is a prospective study, and we don't know what we don't have a gold standard test to determine who definitively has cancer in the PATHFINDER population. So we don't know what the cancer denominator is. So we were able to predict, we were able to calculate PPV, NPV, and specificity, but not sensitivity. We also had some patient participant reported outcomes and perceptions about the MCED test. So this included health-related quality of life and anxiety and perceptions of testing. So I should mention that during the PATHFINDER study, we actually studied 2 versions of the MCED test. The first was an early version, and then there was a second sub-analysis where we refined the test, which is what the current Gallery test is today, in order to maximize some of the metrics, including specificity. And we compared these two. So I do have a slide that looks at the difference in terms of results between the early MCED test and the newer MCED test, which again is the current Gallery test that we're using in clinical situations today. So in terms of kind of overall results, the early MCED test, we're going to focus on the early test, not the Gallery test first. We do have results on the Gallery test. But in terms of the early MCED test, we had patients with additional risk factors, without additional risk factors, and then total. So for those with additional risk factors, there were 3,681 patients. There was a signal detected in 56 patients. True positives were 24 patients, and false positives were 32 patients. And 3,625 patients had no cancer signal detected. The PPV based on these numbers was 42.9%. If you look at patients without additional risk factors, there were 2,940 patients in this group. 36 had a cancer signal detected. True positives were seen in 11, false positives in 24. Cancer signal not detected in 2,904 patients, resulting in a PPV of 30.6%. So this difference between the PPV of 42.9% and 30.6% makes sense because the PPV depends on your pretest probability. And when you're looking at patients with additional risk factors like smoking, cancer, family history, genetic syndromes, their pretest probability is going to be higher. So it makes sense that their PPV is going to be higher than patients without additional risk factors. And the overall PPV, when you combine both these groups, was 38%. So this is just a summary slide going over all the different cancers that were found. So 36 cancers were found in 35 participants, including 27 cancers that are not routinely screened for. So I think this is really a key point. So 18 participants had 19 solid tumors. 17 participants had 17 hematologic malignancies. So there was one patient, obviously, with 2 solid tumors. So the cancers that we picked up included oropharyngeal, breast, liver, bile duct, colorectal cancer, prostate, lung, pancreatic, small bowel, uterine, ovary, and bone. And in terms of hematologic malignancies, the majority of cases were lymphomas. And 14 out of 29, or 48% of patients with non-recurrent cancers had early stage disease, meaning stage 1 and 2 diagnoses. I should mention that there were several patients picked up with a prior history of cancer more than 3 years prior, and we picked up a recurrence in those patients. 25 out of 35, or 71% of patients, there was no standard, we were picking up cancers where there was no standard screening available. So I think this is really a key point, that we're finding cancers that wouldn't have been found otherwise. So this slide really goes over the diagnostic workup and the diagnostic resolution. So in terms of days, the diagnostic resolution in the median days was 57 days in true positives, 162 in false positives, and 79 overall. So it does make sense that the true positives would have a quicker diagnostic resolution, because we're going to have that cancer signal prediction for what organ is involved, and we're going to be able to target that right away and hopefully get a quick diagnosis. If there is no diagnosis based on that organ prediction, then the patient's going to have other tests done to help rule out cancer in other organs, and that's obviously going to take longer. And so that's why for false positives, the diagnostic resolution was 162 days as opposed to 57. So just some summary statements regarding this slide. The median time to diagnostic resolution, as I just mentioned, was longer for false positives than true positives. 73% of true positives reached resolution in less than 3 months, and 50% of those true positive cancers were diagnosed in 2 months or less. I think it's important to state that this study actually took place during the height of the COVID-19 pandemic, when we know that access to clinical care was limited. So I think that it was pretty remarkable that patients were able to achieve this diagnostic resolution that quickly. And hopefully with abatement, hopefully, of the COVID-19 pandemic, we would hope that patients would have an even quicker diagnostic resolution. So this slide really talks about the overall number of cancers that were diagnosed in the PATHFINDER study. So remember, when I was going over the PATHFINDER protocol, we were following patients out for 1 year in both cancer signal detected on the blood test and no cancer signal detected. So 121 patients had a cancer diagnosis within 1 year. 60%, or 73 out of 121 patients, had cancer diagnosed after any screening test, including MCED, USPSTF guideline recommended screening, or non-standard screening. So this is on the left here. These are screen detected cancers. And in terms of MCED testing, 29%, or 35 out of 121 patients, had cancer and an MCED signal detected. So this is the dark blue here on the top of this bar. 40%, or 48 out of 121 patients, had a diagnosis triggered by clinical findings, for example, signs, symptoms, or picked up on imaging for another reason. And this is the right bar here. So 48 of these patients out of 121. Importantly, MCED testing approximately doubled the number of cancers detected with standard of care screening. So this is this left bar. So we have 29 patients having their cancers detected based on USPSTF guidelines, 9 from non-standard screenings that are maybe society-guided cancer screenings, for example, like Barrett's esophageal cancer screening for in GI guidelines for esophageal cancer, things like that. And then 35 were picked up by MCED testing. So again, MCED testing approximately doubled the number of cancers detected with standard cancer screening. And I should mention that many cancers not picked up by the MCED test included cancers that do not have optimal sensitivity, such as breast, prostate, and thyroid cancer. So I already showed you on the prior slide that some indolent cancers, the sensitivity is not optimal to pick those cancers up. So it was not surprising that those cancers were not being picked up in PATHFINDER. And also a lot of those indolent cancers like prostate, breast, and thyroid were early stage disease, so stage 1 and 2 cancer cases. So again, this is really an expected finding. So key findings from PATHFINDER. So MCED testing approximately doubled the number of cancers detected with standard of care screening. 50% of new cancers were stage 1 or 2. There were really no adverse events during diagnostic workups after a signal detected result. And cancer diagnostic resolution was actually quite quick despite COVID-19. And prediction of cancer signal origin really helped direct workup. So I think that's another key point, is that if you're seeing a methylated DNA pattern in the blood and you're able to apply machine learning and predict where that signal is coming from in 90% of cases, that really allows you to hone in on exactly where you should be looking first. So if there's a stomach signal, you're going to go for upper endoscopy, ovarian, you would go down that pathway. So it really helps tailor your workup and make the workup more expedited. Invasive procedures were more common in true positive. I didn't have a prior slide on that, but that was an important point that should be relayed. And the early test version led to relatively few false positives, so high specificity in PPV. So remember, there are 2 versions of the test. There's the early version and the late version, or the refined version. The refined version is the Gallery test that we're using today. So I am going to talk a little bit more about that sub-analysis for the refined version. So specific adjustments were made to the early version of the test, really to make it a better screening tool. So one of the key things that was done was to increase the specificity threshold for heme signals to reduce false positives. So this is due to cancer-like signals from some hematologic conditions that are non-malignant. And we also removed an indeterminate cancer signal origin so that we were able to give you two cancer signal origins, the most likely and the second most likely, but we wouldn't say on the test report that it's indeterminate and we don't know where it is. And then as I just mentioned, the test report now for Gallery allows a maximum of 2 predicted cancer signal origins. So this slide is really a summary slide that compares the early version of the test and the refined version. And we could see that the results are fairly similar, although we were able to optimize certain metrics. So in general, a cancer signal was detected in 1.4% of the early version and 0.9% in the refined version. The specificity was 99.1% in the early version and a little bit higher at 99.5% in the refined version. The PPV increased from 38% overall in the early version to 43.1% in the refined version. And remember that the PPV will depend on your pretest probability. So if you're in one of those groups that's higher risk and has additional risk factors, that PPV is going to be higher. The NPV, also very important metric, was 98.6% in the early version and 98.5% in the refined version. And in terms of predicting the site of origin, the first site that was listed led to an accuracy of organ of involvement in 84%, excuse me, and first or second predicted origin was 88%. So just to summarize the key performance features of the Gallery test, that's the new refined version of the test. The specificity, again, very, very high at 99.5% and a PPV of 43%. And I do want to hone in on this again. So we definitely don't want to be conducting large numbers of MCED testing in a population if the specificity is low, because that's going to lead to a lot of false positives. It's going to lead to a lot of unnecessary patient anxiety and a lot of diagnostic workups. The fact that the specificity is so high is really going to avoid a lot of false positives and avoid that situation where you're just generating lots and lots of diagnostic workups that don't lead to anywhere. And also the PPV, again, is very high. It's about an order of magnitude higher compared to single cancer screenings. So that's another key metric of the test. The other thing, again, the accuracy of the top 2 cancer signal origin predictions was 88%. That allows you to guide your workup. So we're not getting a cancer signal detection and then just saying, oh, do a pan CT scan or PET CT. We're actually trying to predict where it's coming from exactly so that you could tailor your workup and hopefully expedite your workup. And then in terms of the cancers that were picked up, 67% were stage 1 through 3, so non-metastatic disease, and 38% were stage 1 to 2. And again, this is a list of the different kinds of cancers that we picked up. So colorectal, endometrial, liver, lung, etc. So I do want to talk a little bit about the Gallery test in action. So this slide represents the Gallery experience through the first 35,000 tests that have been ordered in a real-world setting. So overall, we've had timely and successful delivery of results. We've detected a number of cancers that lack recommended screening. And an important part of the testing process is that we do provide services for post-test counseling. So if a patient has a positive test result, we have a number of personnel at GRAIL that could help speak to the provider and answer any outstanding questions that they may have. And this slide really provides an additional summary of the 35,000 tests that have been ordered in the real world setting. So 1.1% of tests that were ordered resulted as positive, meaning that there was a cancer signal detected. I do want to highlight that 98.9% of test results are negative. And I think this is a really important point when you're talking to a primary care audience. I know this is not necessarily a primary care audience, but if primary care providers are ordering this test, and let's say we were getting many, many positive test results back that were false positives, that could be overwhelming for a primary care practice because they have to call patients. They may have to have navigation systems in place to deal with large numbers of positive test results. So as a GI doctor, I was dealing a lot of that in terms of positive fit tests. So due to the relatively low specificity of fit testing, I know that primary care providers were overwhelmed every week with multiple positive FIT tests in their inbox, and that creates a lot of work and tracking down patients. But in the case of the Gallery test, fortunately, due to the very high specificity, there are few false positives. So if you do get a test result back that's positive, that's going to be very high yield. In terms of delivery of test results, 98.9% of Gallery orders were issued a test result. It took about 6.7 business days on average for turnaround, and 98.4% of test results were delivered within 10 business days. And this is just an example of what a Gallery test report looks like for those who might not have seen these before. So you will see the top predicted signal origins to guide diagnostic evaluation. So in this case, there was a pretty prominent head and neck signal, and then the second signal was lung. And the length of this bar really is correlated with the likelihood of finding a cancer in this particular area versus that. So in this case, you would go down the head and neck route first. And this is really the final slide. So I just want to summarize that if we think that at GRAIL, we see a better way to assess patients for cancer. And I think we really need to change from only screening for individual cancers to also screening individuals for multiple cancers. And again, I do want to reiterate that this test is not meant to replace USPSTF guidelines. So patients need to undergo their colorectal cancer screening, breast cancer screening, lung cancer screening, if applicable, cervical cancer screening, but our test is able to target the 70% of patients that do not fall, 70% of cancers that do not fall under USPSTF guidelines, and also provide a supplement or kind of a backdrop or safety net for patients that may not be undergoing their USPSTF guideline screening for whatever reason. And that is the end of the talk, and we do have some time for questions. So if anybody has any questions, you can please put it in the chat. Okay, so this is a question from an audience member. Who do you see would be ordering those tests in the future in the clinical setting, PCP or oncologist? So I think that any provider type could be ordering this type of test, but I think at the beginning of the process, it's probably going to be primary care doctors, because what we're doing is we're screening for cancer in general. And so we want to make sure that all different patients that are 50 or older, that's what our studies have looked at for now, would be seeing their PCP and having this test ordered. If there's a positive cancer signal, then the PCP would be referring that patient to a specialist. And then if cancer was ultimately found, they would go to an oncologist depending on what treatment was needed. It's certainly possible that an oncologist could order this test if they wanted to. But it really is being targeted right now for a general population for patients that we know we don't believe that do not have a history of cancer within 3 years. So it would really depend on the situation. As a GI doctor, because the test picks up a large number of GI cancers, I can conceivably see this being ordered in GI clinics. Particularly if patients have risk factors for liver cancer and pancreatic cancer. The only issue is that if we picked up something that is non-GI in origin, like an ovarian signal, we would just have to have a mechanism to refer that patient to GYN or something like that. And then a few more questions. How much does the test cost? And is it covered by insurance? So the answer to the question about the test cost is that the test costs about $949 right now. And it is not covered routinely by insurance, although there are a few select insurance companies that do cover the test. The test is quite new. It's really only been out on the market for about a year now. And we do have a team at GRAIL that's working on the process of FDA approval. And that's really going to be a key issue in terms of widespread insurance coverage. But right now, the test is about $949, but again, we are hoping that we will have widespread insurance coverage at some point soon. Here's another question. If insurance has not approved this, if someone pays out of pocket, and has a positive test, are the imaging, endo procedures, et cetera, covered by their insurance? So that is a great question, and there are parallels to that in the GI world. So if you have a positive stool test, for example, and you had to go to colonoscopy, some patients were getting charged out-of-pocket costs for the colonoscopy. And obviously we wouldn't want this to be the case in MCED testing. So the answer is that we've been monitoring real world patients, and we have not run into that problem where patients have not had their diagnostic testing covered. So that, again, that is, we've been monitoring this and that has not happened. Okay, and here's another question. Of the 6,600 patients, did all get routine screening tests like mammogram, et cetera, as per their age, gender indications, i.e. was the MCED being compared to a group that was heavily engaged in routine screening tests already? So that is a great question. We do actually have a slide on that. And this was actually a very well taken care of population, meaning that a lot of these patients were up to date on their routine USPSTF screenings. So this is definitely a select population. I think I showed you a slide before about PATHFINDER 2, which is going to be a different kind of population where we're looking at more underserved populations. And it's possible that in those populations, routine screening completion may not be as high as in the this current PATHFINDER study. So we're really looking forward to conducting that PATHFINDER 2 study, because it's very important to be able to make sure that this test is available to underserved patient populations. And that certainly strikes home for me because I was GI chief at Denver Health Medical Center, which is a large underserved safety net population in downtown Denver. And prior to that, I was at Tulane and in Louisiana, which also has an underserved patient population. So one of the things that I like about the study protocols at GRAIL is that we're definitely going to be focusing on underserved patient populations to assure that people from different populations have access to this test. In terms of what was the follow-up for heme malignancies, I probably am going to have to answer that question offline, because there's probably sub-analyses that I could get that would help answer that question. So I can't unfortunately answer that off the top of my head, the specific evaluations for heme malignancies or the follow-up for heme malignancies, excuse me. Okay, great. Thanks everyone for attending.